In this lecture, we are going to be talking about the anatomy of the lungs. We're going to be talking about the pathophysiology of a pneumothorax, discuss the diagnostic procedures to determine a pneumothorax has occurred, give you the signs of a tension pneumothorax, and describe the purposes of chest tubes and differentiate between a wet and a dry chest tube and analyze any chest tube reading malfunctions and how to troubleshoot the chest tube. And we're going to also talk about the nurse's role in caring for a patient with chest tube. So what is a pneumothorax? A pneumothorax is collapsing of a lung due to air trapped in the pleural space. Now you have a diagram over here on the right so you can see where the pleural space is. It's in between uh, the lung and the parietal pleura. So it's right in that white area. So air is trapped in that space, the space between the visceral and parietal pleura. And this is an intrapleural space. And when a lung collapses, it can either be a partial collapse or a total collapse. And it's going to affect one lung. And pneumothoraxes are usually due to something spontaneous that happened, trauma, lung disease, central line placement, or mechanical ventilation. So just know that a pneumothorax is air caught between that visceral and parietal pleura, and so if this happens, the air is going to get stuck in that space, and it's going to actually collapse the lung. So we're going to learn more about this in the next few slides. How do we diagnose a pneumothorax? Usually you're going to have a chest x-ray ordered, an ultrasound, or a CT scan to really see what's going on with that lung. And you can see over here on the right, you have air obstruction going on. You have a normal lung, and then you can see the collapsed lung. There are adhesions going on inside the lung. So we're going to find out a little bit more about what a pneumothorax is and how it happens and how we treat these patients. A patient can present with a small pneumothorax, and this is a pneumothorax that can be a collapse of only a portion of the lung. So it's a smaller pneumothorax, and if only a smaller portion of the lung is collapsed, the provider may simply monitor the condition with a series of chest x-rays until the excessive air is completely absorbed and the lung has re-expanded on its own. So it's expected to resolve on its own, and this may take a few days, even a few weeks for the lung to heal on its own. If the patient presents with a large pneumothorax, the patient is going to need treatment such as a chest tube for draining or a needle decompression. So the goal in treating a large pneumothorax is to relieve the pressure on the lung, allowing it to re-expand. Remember, we have all that air trapping on the outside of the lung. So depending on the cause of the pneumothorax, the second goal may be to prevent recurrences of pneumothoraxes occurring. So the methods for achieving these goals depend on the severity of the lung collapse, and the treatment options may include observation or needle aspiration, chest tube insertion, and non-surgical repair or surgery to fix it. What is needle aspiration? Needle aspiration, here's a picture for you on the left. A hollow needle with a small flexible tube, it's called a catheter, is inserted between the ribs into the air-filled space that is pressing on the collapsed lung. Then the needle is removed, a syringe is attached to the catheter and pulls out the excess air, and the catheter may be left in for a few hours to ensure the lung is re-expanding and the pneumothorax does not reoccur. So here's a visual for you on the left. And just remember, it's a hollow needle with a small flexible tube, and it's inserted in between the ribs into the air-filled space that is pressing on that lung. And then we're going to remove the needle, and a syringe is attached to the catheter and pulls out the air. Just to give you another visual of the lung and the lung spaces that we're talking about. So that purple part is the lung, the blue lining is the visceral pleura, and then we have the parietal pleura. And so we're talking about that white space, the white space in between the visceral pleura and the parietal pleura. What is the pathophysiology of a pneumothorax? Well, we have the lungs, we know where the lungs are, and we have our chest wall. And attached to the chest wall is the parietal pleura that we just talked about on the last slide. So there's an intrapleural space, and the visceral pleura attaches to the lung. You can go back and look at the last slide if you need a refresher. And this intrapleural space has serous fluid, so it allows them to glide over each other and create a negative pressure. The lungs love negative pressure. So negative pressure acts like a suction to keep the lungs inflated. So remember that the lungs love negative pressure, and the negative pressure acts like a suction, and they keep the lungs inflated. Here's another visual of the lungs so you can see exactly what we're talking about. So we can see the lung in there, that's the pink thing. Then we have the ribs, the cut end of the ribs. You can see the bronchus, that big tube in the middle. We have our trachea, our larynx, and our epiglottis. And we can see at the bottom right, we have our pleural membranes and the alveoli. Remember, those are the little sacs attached at the end of the respiratory tract. And we have our parietal fluid, and we have our bronchioles, which are coming before the alveoli sacs. So you can kind of get a visual of what we're talking about when we're talking about negative pressure and how there's a serous fluid that allows the lungs to slide between these membranes. And if we get air stuck in there, that serous is going to be gone. So it's going to start sticking to each other. And then our negative pressure system is going to not work very well. So the lung is going to collapse like a balloon. The patient may have an open pneumothorax versus a closed pneumothorax, but we're talking about the open pneumothorax. So the visceral pleura ruptures and releases air into the space. So this can happen with barotrauma, such as if the patient's on ventilation and we put the settings too high. But as air builds up in the space, the lungs cannot recoil. They cannot expand and retract. So the lungs get pushed away from the wall and then they collapse because there's no negative air pressure. We need to keep negative air pressure in the lungs at all times. An open pneumothorax. So there's a picture here on the left side. It shows you what an open pneumothorax looks like. This can happen when there's an opening in the chest wall. So the outside air is getting into the intrapleural space. This can be from a stab wound. So this allows inhaled and exhaled air to pass back and forth. And as it passes in and out, there's a sucking sound. And you might hear this termed as a sucking chest wound. So usually the sound is when the patient is taking breaths through this injury. Is a sucking sound that you'll hear. So if the intrapleural space is equal to the outside pressure and the lung collapses. Remember, our lungs love negative pressure. But now this pressure is equal to the outside pressure, and so the lung loses negative pressure and it collapses. So what you want to do is put a sterile covering over the opening. So the opening is plugged by sealing it with a gauze impregnated with petroleum. So the main thing that you need to understand is if there's an open pneumothorax, that the lung is going to collapse. So you need to cover that chest wound with a sterile pad with Vaseline on it to plug that hole so that we don't get more and more of a positive air pressure going into that lung. A closed pneumothorax. So air leaks into the intrapleural space without an outside wound. So the chest wall and the pleura remain intact, but this can be caused by a rib fracture if you fall down, bony prominences piercing through the tears of the visceral plug of the air. So air is escaping through this tear into the space. The space gets bigger and bigger as it fills up with air, and lungs, as we know, like negative pressure. So this is adding pressure to the lung, so it has no other choice but to collapse. So here is a picture for you of the different types of pneumothoraxes that patients can come into the ER with or spontaneously have on a floor. We have the closed, the open, and the tension pneumothorax. Speaking of spontaneous pneumothorax, this is a defect in the alveolar wall and visceral walls. So this is developing a pulmonary bleb or blister that develops on the visceral layer of the lungs. The bleb can rupture and release air into the intrapleural space, and we know that our lungs like negative pressure, so this is causing positive pressure. And these blebs, or little blisters, they develop over time. So changes in air pressure can cause a rupture. If the patient takes a sudden deep breath and changes altitude, this can all be the cause of a spontaneous pneumothorax. So the primary spontaneous pneumothorax, these occur without lung disease. Usually these patients are young, tall, and thin. And then we have secondary spontaneous pneumothoraxes, and they occur in people with lung disease such as COPD and or asthma. A tension pneumothorax. This is an opening in the intrapleural space itself, and it creates a one-way valve. So air collects in that intrapleural space and it cannot get out. So this is an emergency complication of a pneumothorax. Okay, this is an emergency. So the pressure builds and builds. We're going to have increased thoracic pressure, and the pressure compresses the unaffected lung and heart. So you're going to have this mediastinum shift. So the heart and trachea are all shifted to the unaffected side. So this is when you read those questions or see those patients, when we want to look at that trachea. Is the trachea midline or is it shifted? Because if it's shifted, this can indicate a pneumothorax, a tension pneumothorax. So the shift is going to happen, it's going to go to the unaffected side, and now it's compressing on the other lung. So this is an emergency because we don't want the other lung to be affected, and we need to get that positive air pressure out of there so we can equalize and have no negative air pressure. A tension pneumothorax is an emergency. Okay, so think about, we have our right lung, it's collapsed. It's going to decrease venous return due to the pressure on the vena cava. Now, from our previous lectures, we know what the vena cava is and where it is and what it does. So what are the signs and symptoms you're going to see? Your heart is going to be air hungry, so it's going to try to compensate. So you're going to be breathing harder, breathing faster. Your pulse is going to be increased. So compression on the vena cava, the heart is tachycardic because blood is not getting to the organs. There's nothing to pump. So the patient is tachycardic with hypotension. There's no blood to pump. The heart is trying its best to get as much blood out, so it's going to beat faster, but there's nothing to pump out. So the patient is going to go into shock. And if you see a patient with JVD, this is a late sign of tracheal deviation. So we always want to be on top of our assessments at the beginning of the shift, throughout the shift, and looking at that tracheal deviation. Again, it's going to be pulled to the unaffected side of the lung. Barotrauma. We need to be very careful with our patients on mechanical ventilation because they have a risk for developing a pulmonary barotrauma due to barotrauma from the mechanical ventilation. So extra pressure is going to lead to a buildup of air, and this ruptures the visceral pleura, and a needle deep compression is needed to take out that excessive air. So some signs and symptoms of pulmonary barotrauma. You're going to have a tension. This is a tension pneumothorax, but it's due to patients being on mechanical ventilation. So you're going to have chest pain, you're going to have cough, you're going to have increasing shortness of breath, you're going to be tachypnic, you're going to see asymmetrical wall movement, you're going to see that tracheal deviation. Remember to look for that JVD, although that's a late sign. You're going to have a rapid pulse with decreasing pulse pressure, and you're going to see that shift on a chest x-ray. So for the patients who are on mechanical ventilation, we always need to be assessing their chest wall, assessing the breath sounds, their lung sounds, making sure that they're breathing symmetrically, and making sure that the settings are always correct on these patients. So here's a good mnemonic if you're into mnemonics about the signs and symptoms of a pneumothorax. Think about collapsed. So C is for chest pain. It's not fun. It's not pain-free to have a sudden, you know, uh, collapse of a lung. So they're going to have chest pain with a sudden and sharp, and it's going to be with inspiration. C is also for cyanosis because remember we can't get any blood anywhere because there's nothing to pump. O is for overt tachycardia and tachypnea. The blood oxygen is not getting to the body due to not having any oxygen. So their heart is going to be pumping faster, faster, faster to try to get more blood out to the body, but there's no blood to be pumped out. So you're going to have low blood pressure. Their SpO2 is going to be less than 90. And you're going to hear absent breath sounds on the affected side with the collapsed lung. There's no air moving through that lung, so it's going to be absent breath sounds. Continuing on with our mnemonic for pneumothorax, the P is for pushing of the trachea on the unaffected side. So we're pushing the trachea to the unaffected side. This is a late sign. We're going to have sub-Q emphysema. So what happens is carbon dioxide escapes into the skin, and there are bulging areas in the skin, which when you feel them, they feel like a crunchy feeling. Like if you put your hand in cereal, like Cap'n Crunch. It's like a crunchy feeling when you push on it. It's a crunchy feeling and a crunchy sound. S is for sucking sound with an open pneumothorax. E is expansion of chest wall was going to be uneven because the collapsed lung cannot inflate and deflate. And D is for dyspnea. Your patients are going to be start saying that they are unable to breathe. So what nursing interventions do we have to do for our patients who are at risk for pneumothorax or who have a pneumothorax? Of course, we need to monitor breath sounds. We need to assess the rise and fall of the chest, make sure it's equal. We want to be taking our vital signs. We're going to be assessing for that sub-Q emphysema. It's very weird to feel the very first time. We're going to place O2 on the patient as ordered. The head of the bed, we're going to put in Fowler's position. And if it's an open pneumothorax, remember we're going to place a sterile dressing. Now either you can tape the dressing on 3 sides, or you can put a like a glob of petroleum or Vaseline jelly on the dressing so that you clog that hole, and you're going to maintain chest tube draining system if they have one ordered. So if our patient has a chest tube drainage system in place, we're going to assess for leaks in the chest tube system. And we're going to learn how to troubleshoot the chest tube. So the chest tube used for a pneumothorax is to remove air from the intrapleural space. So on the chest tube, intermittent bubbling is okay. Excessive bubbling is a leak. So for the chest tube, its job is to remove air from the intrapleural space. Intermittent bubbling is okay. Excessive bubbling indicates a leak. When the patient breathes in and out, the water will fluctuate up and down. If the water stops going up and down, it is a kink, or the lung has re-expanded. So remember, the chest tube is used for pneumothorax to remove air from that intrapleural space. Intermittent bubbling is okay. Excessive bubbling indicates there is a leak. Now that when the patient breathes in and out, the water is going to fluctuate up and down. But when it quits going up and down, you need to assess the system for any kinks, or you need to let the provider know, because this may be a sign that the lung has re-expanded on its own. Here is a visual of the chest tube placement. You can see it goes directly into the lung between the ribs. What are some common chest tube problems that nurses have to be aware of and what to look for? So the chest tube drainage system is referred to as CDS in this slide. So we can have poor drainage through the chest tube. Poor drainage through the chest tube can allow the backflow of fluid from the chest tube back into the chest. It's also going to compromise the creation of negative pressure within that pleural space. This is the whole goal, is to create negative pressure so the lung expands on its own. We're going to make sure that the chest drainage system is positioned below the patient's chest. This is going to help with the drainage, it's going to prevent backflow, and our goal is to maintain the water seal within the chest tube drainage system. So you need to check all the tubing, make sure it is not kinked or pinched in a bed rail or inadvertently clamped. In addition, make sure that the tubing is not obstructed by dependent fluid or a clot. However, you are never, ever, ever going to strip or milk the tubing. Stripping is when you pinch the tube at one end and then slide the pinch fingers down the length of the tubing. Milking is squeezing the end of the tube at one end with a succession of squeezes down the length of the tubing. Both of these we're never going to do because both can cause negative pressure in the water sealed chamber and may cause tissue to be pulled into the chest tube inside the chest. So neither technique has been shown to improve the drainage of the chest tubes. We are never going to strip, never going to milk the tubing. Some more chest tube problems. We can have air leaks in the system. So bubbling in the water seal chamber may be an expected pathophysiology of lung injury or an indication of a leak in the system. This is why nobody really likes chest tubes, because they're a simple machine, but there are many problems that can go wrong with it. So bubbling in the water seal chamber, it may be expected or it may be an indication of a leak in the system. But in general, intermittent leaks, air leaks, should be expected until the lung fully expands. So you want to see intermittent air leaks or be aware of intermittent air leaks until the lung has fully expanded. Minor leaks can cause intermittent bubbling when the patient coughs or they're exhaling. They may also correspond with respirations occurring with inspiration. But constant bubbling may be caused by a larger leak resulting from a more serious lung injury. However, constant bubbling may also be seen in a patient on PPV with positive end expiratory pressure. So again, patients on mechanical ventilations, we need to assess what's going on with their settings, and we need to be assessing our patients frequently, and we need to be looking back at the nursing notes to see, has this bubbling been going on? Is this a new finding? Is it intermittent bubbling? Is it constant bubbling? So these are things that you need to be worried about when assessing chest tube patients. Some more chest tube challenges. So air leaks in the system. So if the bubbling in the water seal chamber is constant, it's a constant bubbling, consider that there is an air leak in the system. And so what are you going to do? You're going to try to troubleshoot the bubbling. You're going to make sure all connections are taped and tightly secured. You're going to use a padded clamp to identify the location of possible leaks in the tubing, the insertion site, and the patient. You're going to check to make sure that the tube remains properly inserted within the chest wall, within the chest, and that the occlusive dressing is intact. There could be an infection at the insertion site. So an infection at the chest tube insertion site can spread to the pleural space. So the assessment of the chest tube should occur about every 2 hours, and you should also be looking for the incision at the drainage site for signs of infection. So of course we want to prevent infection, so we need to observe good hand hygiene, disinfecting the chest wall when the chest tube is inserted. We need to maintain a sterile field when applying the dressing. We're going to apply petroleum gauze around the tube, cover it with a gauze dressing, and tape it down. So the goal with this is to secure the tube and close the site with an occlusive dressing We're going to secure the tube to the chest in a position that aligns as much as possible with a resting position of the tube outside the chest. We're going to change dressings regularly according to hospital policy, and we are going to ensure that the chest drainage system does not become disconnected. If the tube is accidentally disconnected from the drainage system and the end of the patient tubing is contaminated, place the end of the chest tube in a 250 milliliter bottle of sterile water or saline to create a water seal while the new chest tube is being retrieved. If the end of the CDS becomes contaminated, of course, we need to change the unit. So if it comes out, if it's disconnected, we need to keep it in water in a 250 ml bottle of sterile water or saline to create that water seal as we wait for the new chest tube system to arrive. Some more chest tube challenges: bleeding and massive hemothorax. So if bleeding is occurring at the site of the incision, you're going to apply direct pressure. You're going to consider the need for blood studies, right? Coagulation studies. You're going to monitor the blood collecting in the CDS, the chamber, document the blood output according to your hospital's policy, and report any sudden increase in output to a physician. Watch for signs of hemothorax, which is an accumulation of blood within the pleural space. So it's not air anymore, it's now blood. A massive hemothorax is defined as 1,500 mLs output initially, or 200 milliliters an hour for 2 to 4 hours. Signs you're going to look for include respiratory distress, absent or severely diminished lung sounds, hypotension, and flat neck veins.